So as you can see from the film, that in Tower Hamlets we have mainstreamed a care planning approach that's based on this different type of conversation, working in partnership with somebody and building on their strengths and what's important to them. Really understanding that people living with long-term conditions are expert at themselves, and that they and the community around them has a lot of assets that we can build on. However, the other reason why embedding in general practice is really important is that we also need to continue to deliver a systematic and structured delivery of evidence-based care. So at the moment, we have bundles of care built around diabetes, secondary CVD and some of the vascular processes, COPD and complex comorbidities. What I think is important to say, though, is that, say, for example, somebody's in the diabetes care planning bundle, that although the diabetes is the opening to that bundle, and that's what will dictate which processes of care need to be done by the admin and HCA teams, that the actual care planning conversation will be person-centred. So if somebody actually wants to talk about their dog dying or their knee arthritis, the things that are making a difference to their life are on the agenda in the conversation. But it's crucial that we get that high-level systematic completion of processes of care. So we've got quite a strongly automated version of that process. And this is just also really a slide. I know that there is a Stockport House of Care, but I think it's really, really crucial to understand that actually to make this work, we really have to have a robust delivery system. So to have that quality conversation, you've got to have people in the room who understand what they're in the room for, who've got the right amount of time to have that different conversation, and that the supporting processes are there so that the information has been fed back to the person, that information about the services, and that includes the community and voluntary sector services, is there, that the commissioning has included resourcing this kind of process, that people and their families understand that that kind of partnership working is wanted. So often people don't in the first instance working this way, they'll sort of, well, you're the doctor, you tell me. And actually we as health and care professionals have to resist sometimes those kind of processes and actually stay with what's important to you. The other thing about this, I think, is just a reminder that the conversation can only happen where people actually are. So that as commissioners at a borough level, you may put a house into place, but you do no actual delivery. And for me, the thing that matters is the actual delivery. So unless those quality conversations, unless that kind of engagement with people and their families and their communities happens, then we're not delivering what we want to. So there are 4 stages in care planning, and this is really just a framework to summarise what I've talked about. So the preparation phase, the information gathering phase, is the bit that I've talked about, in a sense, getting delivery at scale, using the general practice register and really pushing the learning that we've done through QOF to get some of that systematic process evidence-based stuff done. But we then use that in a very different way to feed into the conversation with the individual. So the process stuff is not sufficient in itself. And then I wouldn't want you to go away with the idea that this all has to happen within a general practice. So we have different models. So certainly, for example, the information sharing might involve a results letter. It might involve an educational approach. Certainly some of our practices early on had groups coming to discuss their results letters. It's certainly in some other cases, in NOSL, for example, has involved using peer support to discuss options and so on. And then when you get into the care planning encounter, it may well be that, and in fact it often is the case, that general practices don't know all the things that are out there. And so actually having another person to hand on to, so if you identify a particular goal, for the sake of argument, somebody who wants to increase their levels of exercise, it may be that you use another person subsequently. I mean, we use health trainers, or I don't like the phrase social prescribers, but somebody who really is embedded in the community and understands what resources are out there to help signpost people. And actually, I think this really ought to be cyclical. So that the fact it just shows these 4 stages, in fact, it's a cycle. So the review is feeding into the preparation for the next set of conversations.